Module 15, Chapter 17. So let's descend a little bit more inferiorly and talk about your adrenal gland. Now, the adrenal glands are a pair of glands. They are pyramid-shaped, and they lay on the superior margin of the kidney. Now, each adrenal gland, if you were to look at it in cross-section, can be divided into two major regions. You have the outermost region, which is your adrenal cortex. The adrenal cortex makes about 80 to 90% of the gland's mass. The innermost region is called the adrenal medulla, and this makes up the other 10 to 20% of the gland mass. Now, your adrenal cortex, which is most of the gland, actually does have a yellowish appearance to it. And histologically, it can be divided into three different zones, each zone making a different hormone. You have the zona glomerulosa, which is the outermost, the zona fasciculata, which is the middle layer, and the zona reticularis, which is the innermost layer. How we're going to approach the gland is working our way from the outside in. So let's begin with your zona glomerulosa. The zona glomerulosa secretes a collection of hormones classified as mineralocorticoids. The major mineralocorticoid in humans is aldosterone, a hormone that you've already had to learn in a previous chapter. Now, aldosterone is released in response to angiotensin II. However, it can also be stimulated to be released in response to low blood sodium levels, low blood volume, low blood pressure, or elevated blood potassium levels. Now, what aldosterone is going to do is it is going to target primarily the kidney, but also things like sweat glands, salivary glands, and your pancreas. And in these areas, it's going to adjust the balance of sodium and potassium. Specifically, it's going to tell, and I'm going to refer to the kidney because that's the major area, it's going to tell the kidney to conserve sodium, meaning it's going to pull sodium from the future urine and it's going to put it back into your blood. At the same time, it's going to tell the kidney to excrete potassium. So we're going to take potassium from your blood, we're going to pull it and put it into your urine so that you can excrete more potassium. So these two effects are going to raise blood sodium and they're going to lower blood potassium. Now, with regards to regulating pressure and volume, you've already heard in past chapters that water loves to follow sodium. So if in the kidney you are reabsorbing, you are returning sodium from urine to blood, water is going to follow its osmotic gradient and it's going to follow that sodium back into your blood. So by moving that water volume from urine to blood, you increase your blood volume, which increases your blood pressure, at the same time decreasing urine volume. Aldosterone also targets the hypothalamus, and it actually causes an increase in interest or craving for salty foods. Now, if you crave salty foods and you indulge and eat salty foods, you would be absorbing more sodium from your intestines into your blood, which would raise blood sodium. That movement of sodium also from the intestines into blood would result in greater water absorption as well from what you have ingested and into your blood. Now let's move to the zona fasciculata. The zona fasciculata secretes a collection of hormones called glucocorticoids and a small amount of androgens. But we're going to focus on the glucocorticoids because they're the major secretion from the zona fasciculata. Now, the major glucocorticoid in humans is cortisol. However, there are minor glucocorticoids such as corticosterone and cortisone. Now, the release of the glucocorticoids is in response to ACTH, that adrenocorticotropic hormone from the anterior lobe of your pituitary. Now, when cortisol is released, it's going to have various effects throughout the body. One is that it does promote protein breakdown. And when protein is broken down in things like bone and in muscle in particular, the amino acids that are released are placed into the blood. So this protein breakdown will lead to an increase in blood amino acid levels. It also is going to target your adipose tissue and tell your adipose tissue to increase triglyceride breakdown. So it's going to break your triglycerides down into fatty acids and glycerol, and then these components are going to be put into the blood as well. So this effect is going to increase, in particular, fatty acid levels in the blood. Now, these two effects are providing the cells of your body with an alternate fuel source. So these two particular effects are creating a glucose-sparing effect. The cells of your body will stop using glucose for ATP production. They're going to leave the glucose in the blood, and they're going to shift into using amino acids and fatty acids for ATP production. Now, these hormones are also going to impact your liver, and with the liver, they're going to tell the liver to start increasing glucose production. So the liver is told to take things that are non-carbohydrate, so things like amino acids, lactic acid, and convert it into glucose. In addition, your liver is told to increase glycogen formation. So all of this new glucose plus the glucose that's being left in the blood, thanks to our glucose-sparing effect, all of that glucose is going to be packaged together into glycogen to form that short-term energy storage molecule inside the liver. These hormones also have anti-inflammatory effects. They have the ability to inhibit the activities of white blood cells and other parts of your immune response. Now, if you think about the white blood cells, it's the basophil that releases histamine and promotes inflammation. So these hormones actually inhibit the basophils so that they don't release the histamine and they don't trigger inflammation. Now, there is a downside to being anti-inflammatory. Okay? Inflammation is painful. It's uncomfortable. Anti-inflammatories relieve the swelling, which relieves the pain. However, anti-inflammatories will decrease your rate of healing. So having the inflammation, lots of pain, lots of swelling, but you'll actually heal faster because you're able to bring in all of the different chemicals with your blood that you need for healing. You reduce the inflammation and all of a sudden you take away your source of those needed chemicals and healing is going to be a lot slower. But again, it's a personal decision or a decision you make as a clinician. Are the pros worth the cons if you choose to use an anti-inflammatory? These hormones also depress your immune responses. So if you have ever heard of people with heart transplants, kidney transplants, and after they get the transplanted organ, they have to go on anti-rejection medication. Well, this medication is designed to suppress your immune responses so that your lymphoid system does not systematically destroy this foreign organ. And your glucocorticoids can actually help in depressing those immune responses. However, you have to have them at very high levels in order to prevent your transplant rejection. Now, if you tie this back into your lymphoid chapter, there were two lymphocytes involved in your immune responses. You had T cells and B cells. Do you remember which one attacked transplanted tissue? And I know you're thinking T cells. Well, guess what these hormones are helping to suppress? They're helping to suppress your T cell functions so that they're not attacking this kidney or this new heart. However, your T cells were also important for fighting off spontaneous cancers, also for destroying viral infected cells. So if you are suppressing your immune responses because you have this transplanted organ, you have to be very, very careful with regards to infection because you're not going to be able to fight off those viral infections as well. Also, you're at greater risk for developing cancer because you are missing cells that are designed to help destroy those little spontaneously formed cancer cells. The zona reticularis is our last zone, and this is your innermost zone. And this zone secretes androgens and a really small amount of estrogens and glucocorticoids. Now, these hormones are released in response to really high levels of ACTH. Now, the androgens that are produced have various functions. In males, they play a really important role in fetal development. In fact, it's a surge of androgens from your zona reticularis that actually tells the embryonic reproductive tissues to follow a male pattern of development instead of a female pattern. However, after puberty, these androgens are a very insignificant addition to the large amount of androgens being produced by the male testes. In females, the androgens coming from here actually meet 50% of the female's androgen requirement, and most of these androgens are then turned into estrogens by many different tissues in the body, such as adipose tissue. Now, in both genders, the androgens are going to help stimulate the growth of axillary and pubic hair, also growth of your apocrine sweat glands at puberty, and they also help to promote your libido and your prepubertal growth spurt. The estradiol that's produced in small amounts from this zone in females, very minor importance in women of reproductive age. However, after menopause, they are the only source of estrogens. Now, both androgens and estrogens are going to promote adolescent skeletal growth and in an adult help to maintain bone mass. Now, the adrenal medulla is the innermost region of the adrenal gland. It is stimulated to secrete its hormones by the sympathetic division of the autonomic nervous system. So this part of the gland is actually governed by your nervous system, not your endocrine system. Now, initially, as an embryo, this part of the adrenal gland was actually a sympathetic ganglion. So it was actually a cluster of neurons located outside the spinal cord, and the neurons in here were sympathetic postganglionic neurons. However, the tissues that form the adrenal cortex grew around this they grew around this sympathetic ganglia and basically isolated it from the rest of the nervous system. And once the ganglion became isolated, it started to modify itself. And the neurons changed from being sympathetic postganglionic neurons to what are called medullary chromaffin cells. Now, even though they're not neurons anymore, they still release the same neurotransmitter that they did before. The sympathetic division uses epinephrine and norepinephrine. So these cells still release epinephrine and norepinephrine and a small amount of dopamine. Now, they're going to be stimulated to release these hormones during stressful situations and during exercise. These particular situations are when your sympathetic division of the autonomic nervous system is active. Now, the hormones have a wide variety of functions. They're going to increase your alertness. Again, we're in sympathetic control. We are in fight and flight. They're going to help mobilize your high energy fuels. Your skeletal muscle is told to break its glycogen down into glucose. so that your skeletal muscles use their own glucose for ATP instead of pulling glucose out of the blood. Your liver is told to break down its glycogen and put the resulting glucose into your blood. Your liver is also told to take fats and amino acids and non-carbs, convert them into glucose, and put that glucose out into the blood. Now, this glucose being added by the liver is actually going to support central nervous system function, so that's what it's destined for. Your adipose tissue is told to break triglycerides down into fatty acids and glycerol, and then those components go into the blood, and that effect, that increase in fatty acid level, is going to support cardiac function because you learned that 60% of the ATP in the heart is produced through the use of fatty acids. So if you think fight and flight, the things that are highly active are your skeletal muscles, your cardiac muscle, and your nervous system. And these three effects provide the fuel to these particular organs to make ATP. Now, these hormones also inhibit insulin secretion by the pancreas. Now, insulin is needed for the cells of your body to absorb glucose from your blood. So if you inhibit insulin secretion, your body's cells can't absorb glucose from the blood as well, which is going to leave all of that glucose in your blood for your brain to use because your brain is not insulin dependent. Now, this effect is viewed to be glucose sparing because you're sparing the glucose. Your body organs are sparing the glucose and leaving it in your blood and utilizing other fuel sources like fatty acids and for ATP. These hormones are going to raise your heart rate, which is going to contribute to an increase in blood pressure. They can prioritize blood flow so that you have less blood flow going to organ systems not involved in fight and flight, like urinary and reproductive and digestive, and more blood flow to structures that are, like your skeletal muscles, your cardiac muscle, your nervous system, also your adipose tissue and your liver. You're going to have an increase in airflow to the lungs. Remember, you're trying to produce more ATP, you're in fight and flight, so having that elevated airflow into the lungs is going to maximize your gas exchange. It's going to raise your basal metabolic rate, so it's going to raise your BMR. So you're going to be needing that extra oxygen to produce all of that ATP. It also inhibits non-essential functions, so things that are not going to support a fight and flight situation, like urine formation, digestion of nutrients, the production of, quote, eggs and sperm. That's all going to be suppressed to prioritize the functions that are involved in fight and flight. Our last major endocrine organ is your pancreas. It is located between your stomach and your small intestine. Now, this organ has both endocrine and exocrine functions. About 98% of the gland is focused in on exocrine functions, which will be covered when we get to the digestive system. We're going to be focusing in on the 2% of the gland involved in endocrine function. Now, those endocrine areas are called pancreatic islets, and in the photomicrograph of the tissue on the right-hand side, you can see the pancreatic islet in the center surrounded by your exocrine areas. Now, there are 4 different types of cells found in your pancreatic islets. You have alpha cells, which are about 17% of the gland. They're going to produce glucagon, whose overall function is to raise blood glucose if it is low. You have beta cells, which make up 70% of the gland, the pancreatic islet. It produces insulin, which helps to lower blood glucose if it is high. You have delta cells, which make about 7% of the gland. They produce a hormone called somatostatin, which just so happens to be chemically identical to growth hormone inhibiting hormone, but since it's made by a different organ, you have to give it a different name. Now, the delta cells are going to suppress the alpha and betas. And you need to ask yourself why, right? I said glucagon raises blood glucose when glucose is low, and insulin lowers blood glucose when glucose is high. However, what if your glucose is at homeostasis? What if it is, quote, normal? Wouldn't glucagon and insulin both push that normal level out of homeostasis? So somatostatin is actually produced when glucose levels are, quote, normal, in order to make sure that you don't have the glucagon and insulin present to put you into an imbalance. They've also shown that somatostatin helps to decrease the secretion of stomach acid, also decrease the rate of nutrient absorption in the small intestine, and your rate of digestive enzyme secretion as well. Your F cells, which are 6% of your islet, secrete pancreatic polypeptide. This hormone inhibits gallbladder contraction, but also inhibits the release of digestive enzymes from the pancreas. All right, now what we're going to do is we're going to talk a little bit more about insulin and glucagon. Okay, these two hormones have opposite effects on blood glucose, so we're going to focus in on the abnormal trigger and then what hormone is going to help to fix it and bring it back to homeostasis. So now let's take hypoglycemia. Hypoglycemia is when you have an abnormally low blood glucose, and all of the little cells in your islet are monitoring glucose levels. And when glucose becomes too low, it stimulates your alpha cells to produce glucagon. Now, glucagon is going to stimulate your skeletal muscles and your liver to break down glycogen, but for different reasons. The skeletal muscle is going to break down its glycogen so that it can use its own glucose for ATP. And that's going to keep your skeletal muscles from pulling more glucose out of the blood, which could cause your levels to drop even lower. It's then going to talk to the liver. It's going to tell your liver to break down the glycogen and put all of the glucose that becomes freed up into your blood, which is going to help raise your glucose back towards homeostasis. In addition, it does tell the liver to start producing glucose from non-carbohydrates like amino acids, and then all of this new glucose goes right into your blood to help raise your level. It's also going to create a glucose sparing effect by stimulating your adipose tissue. And it's going to tell the adipose, break the triglycerides down, put the fatty acids into the blood. Those fatty acids then become an alternate fuel source for the cells of the body to use, leaving glucose alone, sparing it in the blood. Now, what if you have hyperglycemia, meaning your blood glucose is elevated above normal? Well, the alpha cells don't get stimulated, but the beta cells sure do. And those beta cells in response are going to release insulin. Now, insulin is going to talk to all of its target cells throughout the body, and it's going to accelerate their glucose uptake, meaning the cells of the body are going to start sucking more glucose than normal out of the blood and into themselves, which will help to lower your glucose levels. Now, to create this effect, insulin is going to upregulate the number of glucose transporters in the plasma membrane, meaning it's going to increase the number of the transporters so you can absorb more. It's also going to tell your targets to use the glucose as quickly as you bring it in, because you don't want to build up unsafe levels of glucose within the cell. So we're going to start increasing our rate of use and enhance our ATP production. It's also going to talk to your liver and skeletal muscles and tell them to start absorbing glucose from the blood and build some glycogen for storage. This is also going to help lower our blood glucose. We're also going to help things by removing alternate fuels. We're basically going to force the cells of your body into using glucose by telling your body cells to remove amino acids from the blood and build protein, and to tell your adipose tissue to remove the fatty acids from your blood and build triglycerides for storage. Now, before we leave the pancreas, I do want to talk about diabetes mellitus. As you're aware now, there are different causes for diabetes mellitus. One that was mentioned in another module is hypersecretion of human growth hormone. However, the hyposecretion or inaction of insulin will also cause diabetes mellitus. Remember, insulin is responsible for lowering glucose if it gets high. If you don't have the insulin, or it can't create effects within the body, you are not going to be able to lower those blood glucose levels. Now, there are many different symptoms of diabetes mellitus. For example, there's an increase in urine output, which is going to dehydrate your body very quickly, which is why you also have an increase in thirst. You're going to have higher glucose concentrations in your urine because you're trying to get rid of that overflow of glucose. You're going to have this intense hunger because the cells of your body are basically starving. It's almost like your cells are on a desert island with no food. They can't recognize that there's glucose available because there's no insulin to tell them to use it and to bring it in. So you get this constant hunger and, of course, the increase in blood glucose. Now, with type 1 diabetes mellitus, this accounts for about 5 to 10% of the cases of diabetes mellitus that occur. There has been data to show that there is a very strong genetic predisposition for developing type 1 diabetes mellitus. And normally, if you have this genetic predisposition, the diabetes mellitus develops after contracting certain types of infections. Now, what happens is the beta cells within the islet are actually destroyed by autoantibodies. These are antibodies produced by your lymphoid system that are attacking healthy body cells. So your lymphoid system basically demolishes your beta cells. Now, type 1 diabetes mellitus usually occurs before age 30, okay, usually. Because you have lost your beta cells, you have no personal source of insulin production. So type 1 is managed by insulin injection. Also, very careful meal planning and exercise. Now, type 2 diabetes mellitus is usually described as insulin resistance, meaning the targets within the body become unresponsive to the insulin. So even though you can make the hormone, your body cells can't respond to it. So the insulin, there's inaction of insulin, and blood glucose levels stay high. There is a genetic predisposition for this. However, age is a factor, obesity, having a sedentary lifestyle. These are all risk factors for developing type 2 diabetes mellitus. Now, usually type 2 diabetes mellitus occurs after age 40. However, as our children in the United States become more obese, there has been a growth of type 2 diabetes mellitus in children. And it's directly related to obesity because they're sitting at computers instead of going outside and running around, and the fast food and the other junk food and all of that playing into the poor health of the children. And we're starting to see something that normally people didn't get until they were older in little kids. Now, most treatments for type 2 involve diet and exercise. However, because of the constant strain on the pancreas, you can suffer what is called beta burnout, where the glucose levels are so high, your beta cells are being overstimulated, they are constantly making insulin, and the cells don't get destroyed, but they wipe out. They get tired, they fatigue, and the cells themselves just stop working. And at that point, your pancreas really can't make the insulin because with the type 2, it has been stimulated so long. So the insulin therapy is necessary until your pancreas recovers and can begin to produce it on its own. And that beta burnout will also happen with human growth hormone causes for diabetes mellitus as well. All right, so for the rest of this module, we have some more of the minor glands to cover. The pineal gland, which I love to talk about in A&P1, love to talk about in A&P2, is a small pine cone shaped gland which is part of your epithalamus. So it's up in the diencephalon of the brain. It's very close to the roof of the third ventricle, right in the midline, and the cells within it, called pinealocytes, secrete a hormone called melatonin. Now, melatonin is released in darkness and at very low levels during sunlight hours. So it's tied in with our night cycle. Now, with regards to what it has been proven to inhibit reproductive functions. In animals that breed seasonally, melatonin is going to make sure that the animals don't breed out of season to help ensure the offspring's survival. In humans, it does play a possible role in the regulation of puberty onset. They have found that young children, so prior to puberty, have really high levels of melatonin. However, at puberty, those levels drastically drop. And when they drastically drop, you start to produce gonadotropin releasing hormone from the hypothalamus, which begins your reproductive cycles. So they do believe that these changes in melatonin level do play a role in regulating when puberty sets in for individual humans. It does offer some protection from free radical damage within the brain. So it offers a little neuroprotection in certain types of central nervous system disorders. It also sets what are called circadian rhythms. Circadian rhythms are daily changes in physiological processes that follow a 24-hour day-night cycle. And because this hormone is produced in darkness, it helps to set in that night cycle. For example, it makes you drowsy in the evening. And if you feel drowsy, you're more likely to get ready for bed and to initiate your sleep phase. Now, there is a disorder associated with this gland. It's called seasonal affective disorder, or SAD. And this is actual clinical depression. Okay? This seasonal affective disorder is a type of depression. And what happens is that you start to build up really, really high levels of melatonin in the brain because you are exposed to very limited sunlight. Now, this is not going to be commonly encountered here in Florida, but if you were to move to Alaska, where for 3 to 4 months out of the year, in the winter, you have 1 hour of dusk and the rest of the day is dark. My cousin Carol lived there and hated it. but she was fine. She didn't get seasonal affective disorder, but her husband Dave did. Their first year there was horrible. The moment winter hit, he started sleeping all the time. He was very depressed. And what they found out is he had really high maintained levels of melatonin because of the constant dark exposure. And the therapy for it is actually fairly easy. All you have to do is sit under a special light bulb, which mimics sunlight. So it's full spectrum sunlight, but he would sit under that for about 3 to 4 hours a day, every day during the winter, and it was enough of a break for his pineal gland to stop producing melatonin and to give his brain time to metabolize the melatonin that was accumulating during the dark hours. And it was very effective for him in alleviating the symptoms of depression. Your thymus, which is located in your mediastinum, it's also considered a gland because it does secrete the hormone thymosin in addition to other thymic hormones. These hormones are needed to help promote T cell maturation. Recall from your lymphoid chapter that T cell maturation is when they become immunocompetent, capable of mounting an immune response. These hormones also help to stimulate the development of other lymphoid organs, meaning these hormones can leave the thymus, enter your blood, and travel throughout the body. They have also found that these hormones help to retard the aging process. So again, when you're dealing with the thymus, recall that it was that big gland that gradually died throughout your lifetime. So by the time you get into your 60s and 70s, this gland is so small that it's just a mere shade of what it used to be. It has very reduced functions. And if you think about it, as this gland dies, you lose its hormones. It stops functioning like it did before. And what happens as you get older to your appearance? You start to look older. So it's believed that the loss of these hormones from the structures of the body promotes the signs of aging that you see as you get older. Now, there are other hormones produced by other endocrine tissues. There are some hormones produced by the gastrointestinal tract, but we'll cover those in Chapter 25. There are hormones made by the placenta itself, that little connection between the fetus and the mother. One is called human chorionic gonadotropin, which is abbreviated HCG. HCG is actually necessary for maintaining pregnancy during the first trimester, so those first 3 months. Now, you'll learn why and how when we get to the reproductive system. But for now, okay, this is made by your placenta, which is actually kind of curious because if it's made by the placenta, HCG is not in non-pregnant females because you don't have a placenta unless you are pregnant, which is why this is the hormone that is detected with pregnancy tests, right? So if you're pregnant and have HCG, you'll have a positive result. If you're not pregnant and have no HCG, you'll have a negative result. Your placenta does produce some estrogens and progesterone, but again, those are going to get covered in with female reproductive in Chapter 28. You also have human chorionic somatomammotropin. Now, I promise I will not use that as a fill in the blank. That's a stretch. This particular hormone is going to work with other hormones in the female to help stimulate mammary gland development and promote lactation. Your kidneys produced a whole bunch of hormones. Because these were covered in past chapters, I'm going to assume that you can go back in your lecture notes, look these hormones up with their effects, and review them in time to take your exam. So I'm not going to re-lecture on everything about them. But recall that your kidneys produced renin. You learned about it in Chapter 20, and renin led to a series of chemical reactions that led to angiotensin II. And angiotensin II had all of its lovely functions, which I would highly recommend that you go back and review as well. You have erythropoietin, which you guys learned about in Chapter 18, calcitriol, that lovely active vitamin D, covered in A&P1 in Chapter 7. You had the heart producing atrial natriuretic peptide. It was covered back in Chapter 20, so please make sure you go back and review your notes. You then have adipose tissue. Now, adipose tissue we haven't talked about yet. Adipose tissue produces a hormone called leptin, which helps to regulate your appetite. Now, how this works is that if you have low levels of body fat, then you produce low levels of leptin. The low level of leptin allows for you to have an increase in your appetite and an increase in your food intake. However, if you have high levels of body fat, then you produce high levels of leptin. The high levels of leptin are going to suppress your appetite and your food intake. Leptin also has been shown to be a possible signal for the onset of puberty, and it does so by increasing follicle stimulating hormone and luteinizing hormone activity. Now, all of those hormones are all in there all together. You don't just have in your blood one hormone at a time. So it's reasonable to assume that hormones are going to interact with each other. So what we're going to do now is just talk about different ways that your hormones can interact with each other and what that means for you. Now, the first one, which is usually the easiest one for students to grasp, is something called an antagonistic effect. And this is when one hormone opposes the action of another hormone. And we in this module covered one, insulin and glucagon. Insulin lowers blood glucose, but glucagon raises blood glucose. And then didn't you have parathyroid hormone and calcitonin? They each had an opposite effect on blood calcium levels. So that's one way that your hormones can interact, by having opposite effects on the same physiological value or factor. You then can have a synergistic effect. In a synergistic effect, you have two hormones interacting together and creating a greater effect than when they act independently. So, for example, follicle stimulating hormone and estrogen. With regards to, quote, egg development, follicle stimulating hormone will initiate egg development, but it alone cannot finish egg development. Estrogen can't wake up, quote, wake up your eggs to begin developing, but it can help them to complete development. So neither of these hormones can fully develop an egg on their own, but if they work together, they can lead to the full development. Same thing in the male testes with follicle stimulating hormone and testosterone. Neither hormone on its own can accomplish full sperm production, but the two hormones working together can accomplish that goal. The last effect can actually be the hardest one to grasp. It's called a permissive effect. So before I get into the specifics that are on the screen, I just want to give you a real life example of how it could work. I have a daughter, you're all aware. She goes to Taylor Ranch up the street. Now, when there is a field trip, for her to get on the bus to go on the field trip, she has to bring home a permission slip, and I have to give her permission to go. Now, I personally am not going to get on the bus to go on the field trip, but I have to do my job first in order for her to get on the bus second. Permissive effects with hormones work the same way. You need one hormone to do its job first, basically give permission, and then a second hormone can come in and be able to do its job. So you need one hormone to come first, basically to give permission for a second hormone to have its job completed. Now, the best hormonal example I can give you is the relationship between epinephrine and thyroid hormone on adipose tissue. When you start thinking about these two hormones, if epinephrine arrives at your adipose tissue and thyroid hormone has not gotten there first, so epinephrine arrives, thyroid hormone nowhere to be seen. Believe it or not, epinephrine has very little effect on adipose tissue. Okay? By itself, it only very weakly stimulates the breakdown of triglycerides. However, if thyroid hormone gets there first, thyroid hormone causes the upregulation of epinephrine receptors. So thyroid hormone comes in, does its job. It increases the number of epinephrine receptors. Now epinephrine arrives and has the ability to have a massive impact on adipose tissue and really cause significant breakdown of triglycerides because thyroid hormone gave it permission to do its job.